since 1990. He was the executive director of the Lower East Side Harm Reduction Center, one of the first syringe exchange programs in New York State, and of the Harm Reduction Coalition, which is the prominent community-based organization promoting harm reduction as a mode of working with drug users in the U.S. Mr. Clare has served on both local and international advisory bodies, including Governor Cuomo's and the Epidemic Task Force in 2015 and the United Nations Civil Society Task Force on Drugs. Welcome, Alan Clare.
Thank you. There we go. Is that good? Thank you, Sharisa, for that introduction. And I was saying beforehand, I've got a whole bunch of slides. I'm not sure if I'm going to get through all of them. I'm going to try and finish by 1:45 and do some questions and answers. And the Office of Drug User Health at the AIDS Institute has been in existence just since February last year. And as probably many of you know, there's been in terms of HIV and drug user health, the AIDS Institute has been running programs and initiatives for actually since the late 80s, where it provided support and funding for primary health care in methadone programs. So the Office of Drug User Health brings under one umbrella several aspects of the initiatives that the AIDS Institute has had running for a number of years. So syringe exchange, which started in 1992, then the ESAP program, which is the pharmacy-based access to syringes, and also physician prescribing of syringes and the ability for Article 28 to give out syringes. That's the ESAP program. Then in 2006, and I'm going to talk quite a bit more about overdose shortly, the overdose program was started at the AIDS Institute, and that's principally the training of providers and lay people and folks in the community and the provision of naloxone to respond to an overdose situation. Then last year, we started two new programs, really. One is funded under prescription drug overdose prevention grants, which comes from the CDC. And then in response to the opioid overdose crisis in New York State, we sort of gave a program a name of Drug User Health Hubs, which is really thinking of drug users and the way they use their drugs as a health issue, rather than siloing as we might have done in previous years in terms of syringe exchanges for HIV and maybe hepatitis C, and we got overdose over here. It's all one of a kind for people who use drugs. And I'm just going to locate what I'm going to say in this slide here, and you may or may not be familiar with it, but this is hepatitis C cases by age and sex and year. So if you look at the top 2005 bell curve, you see that hepatitis C is impacting those people in their early 50s. And you look at the blue lines and you see that those are women, the orange lines are men. By 2012, just 5 years ago, you see the bell curves begin to change and the development of a second bell curve where the blues and the oranges of the under 30s sort of coincide. So you've got young men and young women getting infected with hepatitis C under the age of 30. And then you look at just in 2015, you have two pronounced bell curves now. You've got the older generation who have moved on now, they're in their mid-50s and 60s, but you have this high rate of incidence of hepatitis C amongst men and women, which is, what that indicates obviously is that young people are using drugs, injecting drugs in a way that we haven't seen maybe before. Or maybe now we have the technology to understand it. Related to that, you can see here the steep increase in opioid overdose deaths that have occurred over the last few years. You know, we saw a decline down in 2010, which a number of factors have contributed to the increase in opioid overdose deaths over the last few years. But basically, this picture is just to show you that just to show you how steep it is and the impact that opioids are having in New York State. You're probably aware of the ongoing conversation about the presence of fentanyl in the heroin supply. And this is for New York City DOHMH. This is their slide. This is their data. But just a couple years ago, you saw very little fentanyl in the heroin that people were buying on the street. In terms of overdose deaths in 2015, it was 16%. But now fentanyl is implicated in 47% of all overdose deaths in New York City. And it's going up. And there's a lot of, I'm not sure that the reason why we have fentanyl in the heroin supply is completely clear yet. It would seem to me that when people market heroin, that they're moving away from a plant-based economy where you have to worry about harvesting poppies to a factory-based economy. And so we see here this is from Buffalo. And you see again fentanyl related in 43% of the cases in 2015. But you also see it's going up to 59%. And that, I might be wrong on this. No, that's right. So fentanyl, this is just fentanyl, it's not even heroin. So when folks are going out to buy heroin, more and more frequently now we're finding that what they're buying is actually just fentanyl. And there's still heroin about, but again, it would seem that the trajectory is to be more of a market for fentanyl and not a heroin. We're not going to see much heroin in the future, perhaps. So that clearly is a problem because fentanyl, the strength of fentanyl compared to heroin is so much greater, and the fact that you can't mix heroin you can't mix fentanyl so easily into the cut that people are buying, so people don't know the actual strength of what it is that they are buying and purchasing. And you do hear a lot about how dealers, for example, are callous and indifferent to human life, but we're not actually sure that most dealers are aware of what they're selling at all, and the fentanyl arrives into this country and gets mixed at a much higher level than most of the dealers will ever see. So it's not necessarily about what the callous intent of people selling, and very often dealers and drug users are pretty much the same population. So in recognition of the fact that young people are using drugs at a higher rate than we've seen before, and given the intensity of the opioid epidemic in New York State, the AIDS Institute has funded a young IDU initiative through its syringe exchange programs to bring in younger users and to figure out how we can interject earlier in the trajectory of the lives of people who use drugs. So what we do know, and I've got a slide later on actually, that about 50% of all new enrollees in syringe exchange programs outside of New York City are under the age of 30, which shows that in this particular case a tiny bit of money went a long way, but also that again, just reaffirming that young people are using drugs in a way that we haven't seen for a long time. So I mentioned the drug user health hubs, and it was not long after I came to the AIDS Institute that the questions were being asked about what do we do beyond naloxone, which in and of itself, naloxone has been a tremendous initiative of the State Department of Health, and the amount of coverage that we've managed to put out there in terms of naloxone to address opioids has been quite astounding. But how can we reach people who are not necessarily connected to services, and by which mechanisms can we connect those folks to ongoing care? And I think the dialogue is often very much around, when we talk about opioids or drugs, it's drug prevention. So the prescription drug monitoring programs that the New York State and all the other states have put in place to monitor and control and watch how prescription opioids go out into the community, we often say that the answer to this is drug treatment. And then, of course, law enforcement has a big role in addressing the illicit drug use. What we tend to miss out is the fact that people who are drug involved, and it doesn't matter where you are on the spectrum really, whether it's you're younger and you actually don't have a dependence, in which case drug treatment would be completely inappropriate, or whether you are a very dependent person but not ready to be in treatment, or maybe you don't want to go to treatment, or maybe you have been in treatment and the treatment system does not work for you. There needs to be some kind of role for support for those folks, and we tend to ignore that completely. And just from my experience, that we tend to think that drug treatment is one episode or 2 episodes in some kind of treatment facility, but it seems to me that what we call drug treatment, or what we call some kind of pathway towards some kind of recovery, is usually multiple interactions with the social service system, with the medical system, and with maybe with the treatment system. Although remember that most people move away from problematic drug use without going through drug treatment. So we created these pilot hubs, and the hubs are pre-existing, long-standing harm reduction programs. And I was looking for a way in which you can connect someone who's experienced a drug overdose. Maybe they've been picked up by the ambulance services, advanced life support. Maybe they're in the emergency departments. They've been revived by EMS, or they're in the emergency department and they're recovering. Maybe family members don't know what to do with folks. Or maybe simply law enforcement want a place to connect people to. And I have to say, over this opioid crisis has sort of transformed the relationship between law enforcement and people who use drugs, I think. Not fully, but you do see so many people that are drug involved, and maybe family members of law enforcement or corrections, that there's a little bit more compassion from law enforcement towards people who are using drugs. So what we're trying to do is make these connections so that someone can be connected to somebody, because I think that is one of the keys, that people walk out of ambulances, walk away from overdose sites, walk away from emergency departments with no connections to ongoing care or support or information or education or materials. And when you're presented with someone who has this health issue, then this is an opportunity to actually intervene. And I'm not going to one of the shifts for me, I think, in taking this job is I tend to think now in terms of Albany and Ithaca and Buffalo and Rochester, and I didn't realize there were so many counties in New York State, and much less so on New York City. But we work really closely with New York City DOH, MH, and they're looking at something very similar, interventions too. And Mount Sinai may be part of what they're doing. They're working on rolling out non-fatal overdose response teams. So when someone shows up in an emergency department who's overdosed, someone will come and talk to them and connect them with ongoing support and care. So what we see as some core elements of those programs is access to sterile syringes, access to buprenorphine, access to naloxone, and we'd love to see some hepatitis C care there too as core elements of these programs. But the hubs also supply a whole range of other healthcare and connections, and just a place to go where you don't experience the stigma that you might experience in other healthcare settings, where someone can talk about what's going on and what they want to do and how they use their drugs and what they want to do with their lives. So as I said, let me see what next slide is. Oh, let's go back. Whoops. We've got 3 or 4 of them going right now. There's Albany, Ithaca, and Buffalo. And there's also a hybrid version on Staten Island, working with Community Health Action in Staten Island. But I'll just give the example. Actually, I'll give the example of Albany and Ithaca. So Albany, we picked Albany because they're involved in the law enforcement assisted diversion program, which which is the non-arrest, the non-booking piece of addressing repeat offenders, low-level offenders, or although all the way up to felonies. Those folks, instead of being arrested and put into the system again, are sent to Catholic Charities, the program that we work there with. At the same time, Albany, aside from just those folks that are in the lead program, Albany PD are now referring folks that are in the emergency departments. They're connecting them to Catholic Charities, and also those people that are taken are post arraignment, and in terms of being arrested, they have felony charges pending. They're being steered towards some kind of social services in the connection with Catholic Charities, and it differs from drug courts in the sense that it's not about taking a plea. It's not pleading guilty to anything. You actually don't go there with any charges if you're in the lead program, but you go there and you get some kind of support. And I'll talk about Ithaca as well. Ithaca chose to use their money to hire an emergency department physician and some nurses to work at Southern Tier AIDS program. What we had been hearing is that the buprenorphine that was available in Ithaca was too high threshold for so many of the people there. So many requirements in terms of what you have to do to keep your prescription going, that they hired someone who was going to start prescribing straight away at the syringe exchange program. So the nurses do the triage, the doctor does the prescribing, and because she was in the first year, she only had 30 slots. So she filled those slots in 3 days and immediately got a 60-patient waiting list, which just goes to show the need there is out there. And if you think of a small town city like Ithaca, if you can get 90 people onto buprenorphine, you can actually address quite profoundly the overdose deaths that are happening in Tompkins County. So I will, and actually it's really heartwarming. Those folks there that have been inducted and are now on buprenorphine, and the doctor is beginning to pass on some of them out to physicians in the community, so it is like a hub and spoke model. But those folks that use the needle exchange are now on bup are forming their own support groups. They're getting together once a week to talk about what it means to be on bup, syringe exchange, and in recovery because of the stigma associated with buprenorphine and recovery. They're hooking up to go camping and hiking. A bunch of them have gone back to work already, and 2 people have enrolled into higher education. So, and this has only been going on for basically 3 months now. So, I'm just going to this again is just another snapshot of what we're seeing in New York State. Syringe exchange programs, you're probably all aware, have been around since 1992, and they provide all the support services that a person might need to the best of their ability, which is why we're locating hubs in these programs. But they see an enormous amount of people throughout the year. And I think one of the issues we're faced with is how to intervene with people who are not injecting drugs, and not that maybe that they will move on to inject drugs, but how can you intervene before they get to that point? I just want to go back to what I think we maybe should be doing in terms of the fentanyl epidemic here. These programs, there's 23 around the state, there's 14 in New York City. Many of them have multiple sites. All of them have wraparound services to go with folks when they come in to get their syringes. They can pick up a whole bunch of other services at the same time. When we know that the heroin supply is so contaminated with fentanyl, we should actually be talking to every single person that comes in to ask them, are they trained in the use of naloxone? Do they know where the naloxone is? Do they have it on them? Have they recently come out of drug treatment? Have they recently come out of corrections? And then talk to them about what it now means to use heroin in 2017 in New York State, or actually in America. And I think that this probably doesn't just apply to syringe exchange programs. It certainly applies to drug treatment programs, but it would it would apply to folks that come across people who have a history of opioids in hospitals, primary care, emergency departments too, to make sure that people are completely aware about what's happening. And I think that, like everyone, like all other humans, we tend to think it's not really about the things that we're doing, or that we're not going to be that impacted. So these conversations sort of break through that healthy human boundaries and denial, and people begin to think about how they can use their drugs in a different way. So I imagine that most of you are familiar with buprenorphine. So it does a number of different things. It certainly impacts opioid use disorder and takes away the cravings that people who are dependent on opioids experience. But also, it's extremely effective. It's extremely hard to overdose while you are on buprenorphine. It doesn't mean you can't, we wouldn't encourage anyone to try. But if you have, when France had addressed their opioid overdose problem, they actually rolled out a lot of buprenorphine and brought the numbers of overdose fatalities down. If you look at some of the data of what you find in decedents of opioid overdose, you won't find very much buprenorphine, which sort of indicates that buprenorphine is providing this protective factor. So, and for someone who is dependent on opioids and needs to go out and find drugs every day, the stability that buprenorphine gives you allows you to rebuild and restructure what you do in your life and move on maybe from your negative relationship to drug use. So, and it obviously cuts down on HIV, risky injection behavior, and therefore reduce HIV and hepatitis C transmissions. And of course, there's lots of benefits for the community as well, in terms of people don't have to go out and raise money in nefarious ways to buy their drugs. It also cuts down on emergency departments and healthcare visits as well. But there's a lot of barriers to rolling out buprenorphine. I should say this is one of our initiatives this last year, that we're trying to encourage physicians and now nurse practitioners and PAs to think about making buprenorphine more readily accessible to people with opioid problems. And you can see all these, we've had conversations, we're all probably pretty familiar with the barriers to prescribing buprenorphine. But we can prescribe as many opioids as we like without a patient limit, and yet there's a patient limit on buprenorphine, which is a solution to people dependent on opioids. What we see in rural upstate is they have no access to, folks don't have access to methadone programs. They have very little access to any kind of opioid use disorder treatment. So that's another reason why we want to get buprenorphine into rural areas of the state. And one of the things that was surprising to us, I think, when we started working on this, was that we would hear from our providers who were trying to get people onto buprenorphine that they would call a physician or a practice, and they would say we're at our limit, which you would assume would mean they've got 30 patients on buprenorphine. But what it often meant is like somewhere between 3 and 10. What it meant was this artificial limit that providers were putting on the amount of folks that they were going to see and prescribe to in their practice or in their clinic. And what we're trying to work on is trying to get more providers to be waived and to start prescribing, and to folks that are prescribing to take on some more patients and begin to think about how you can increase your practice, the amount of patients you have in your practice on buprenorphine, because it makes a tremendous difference. And we used to talk about low threshold access to buprenorphine, and I think that sort of raised too many questions, so I won't mention low threshold access to buprenorphine, but just points of access for buprenorphine. And the State Department of Health, we interact with the Office of Alcohol and Substance Abuse Services quite regularly, and that's the treatment end of, the state system. And I think we see things slightly differently. To my mind, the primary issue on hand is keeping people alive. The issue is too many people are overdosing. Drugs out there in the community are very, very risky right now. And I think that when you work in a treatment agency, what people want to see happen is for people to recover and be in drug treatment. And so from our perspective, what we're trying to do is reduce overdose fatalities and all the other bells and whistles that go with buprenorphine, such as whatever you might want to provide, the weekly support groups. As long as they're sort of available and you know where they are and you can advise people to go to them, as long as you have that great therapeutic relationship between a provider and a patient, you're doing most of the work that you need to do to help that person recover. So we would like to see buprenorphine in all kinds of different settings. Like I say, we've been funding the hubs programs, but also supporting some of our other harm reduction programs just to provide buprenorphine, add that on to the other services that we're providing. Primary care would be a great place for someone who's coming with experiencing an overdose, for them to go home with a connection and for a few days' supply of buprenorphine. And again, I was talking to a health commissioner from one of the counties, and they're doing great work. But what they're thinking, and they're going to start prescribing buprenorphine in the emergency department as drug treatment. And I think that when you are a person who uses and are dependent on opioids, when you hear drug treatment, it's very different from when the person using those words uses them. The drug treatment is an enormous change. You might well be tired of using drugs. You might well be completely freaked out about the fact that you have just nearly died. But you might not be willing to go what you think of as those extra steps to go into some form of drug treatment which is going to change your whole life. So why can't we just sell buprenorphine as something that's going to cut you some slack? Take a break. You don't have to go out and score tomorrow if you take this pill. Let's see if you like it. Come back. Let's check it out. And sort of change the sort of tenor of what we're saying to folks when we're confronted with someone who is basically at risk of dying. Once you've overdosed once, you're much more likely to overdose again. So all of these points of access would be lovely places to roll this out. Correctional and reentry especially. And like I say, we're looking at young people, but also when you've got so many young women using drugs, that means a lot of people who are going to get pregnant and are using opioids. And for us to begin to address pregnancy and opioid use and then neonatal abstinence syndrome, no woman without some kind of support related to their opioid use. And we have to sort of address the stigma that goes with being a pregnant woman who is using drugs. So we're looking at all these things. And it's, just last week or the week before, we just at New York State put out the emergency regulations now, so the PAs and MPs that were authorized to start prescribing buprenorphine in the CARA Act. Now they can start doing it in New York State. So any of you MPs and PAs out there can start doing the trainings and begin to start prescribing. So I'm going to switch gears a little bit just to look at the naloxone program that we've been running since 2006. We started tracking really in 2014 the people we were training. So you can see there, even though it says 83,000 people, it's actually around 140,000 New Yorkers have been trained on how to recognize an overdose and how to respond to it and have received naloxone. And it expanded from, when this program started, it actually started in syringe exchange programs with drug users. Because we tend to forget that drug users are very competent at taking care of certain things in their lives. Given the knowledge and accessibility, access to care, that they will actually take control of things. And drug users are on the site more frequently of an overdose than any of us. So in a sense, when we talk about first responders, drug users are first responders. So these large blue lines very often are drug users, but also family members and community members. But we expanded that. It's naloxone training and provision of naloxone into schools, EMS, firefighters, law enforcement. We're also in corrections now. And law enforcement are the best reporters of naloxone usage because it's part of what they do. So they'll be on the scene of a drug overdose. They'll revive someone with naloxone, and then they report it back to us. That's part of what they do. And our community-based administrations are so underreported because there is no mechanism for someone to report, really. And we are working on that. But again, it's probably not the first thing they think about in terms of reporting back to the health departments when they've used the naloxone. So we know that the blue piece of this pie chart is underreported. But it does go to show what an impact the naloxone program has had. Like I say, we're impacting all these different areas in naloxone. We'll get to pharmacy in a minute as well, and also corrections. But we now have over 400 programs that are registered opioid overdose programs. I talked about, we've got firefighters on there. I talked about drug users being first responders, but police and firefighters are often first on the scene, especially, again, upstate police are very often there before EMS. And we're doing this work now in 10 state prisons. So we go into the prisons, we train folks who are about to come home, and anyone who wants to pick up a naloxone kit can pick that kit up on the way out. So we're sort of arming people to protect themselves when they leave the correctional facilities. This the pharmacy programs. The reason I had this slide in here actually really is because with some kind of encouragement, insurance companies are now all covering some form of naloxone or another. So pretty much any of your patients that have that need naloxone can go into a pharmacy and pick up naloxone. It's their understanding our order. It doesn't have to be patient specific, but insurance will cover it for anybody. And this is the docs training that I was talking about. So we have just over 5,000 inmates trained, 2,500 are taking kits, and we're trying to get into the state correctional system to every single state prison so that people are protected when they come home. I talked about young IDUs, and you can see, even though I focused on upstate a little bit earlier, Western New York is Buffalo, really. I guess in Rochester. Or was it Syracuse? I still haven't got my geography down. But they have, a second to New York City, that they have, well, actually, maybe ahead of New York City in terms of overdose fatalities. Buffalo is sort of leading the way. But even New York City has seen over 2,000 young IDUs just in the last year alone. Taking advantage, I'm just going to talk about this briefly, taking advantage of the fact that we have people at risk of contracting HIV, sexual risk, people who are HIV positive. We are piloting 4 programs with providing those people that qualify for PrEP. We're doing a lot of education, we're doing a lot of contact, we're doing a lot of outreach, and we're doing a lot of connections around PrEP. The 4 programs, we've got 2 of them in New York City, 1 of them in the North Country, and then Syracuse as well. And then I think I'm going to finish on this, actually. So some of you may be aware there's the whole Ending the Epidemic work that's been going on in New York State with the goal of pretty much getting to zero by the end of 2020. When last World AIDS Day, Governor Cuomo announced that he wanted to get to zero HIV transmissions through injection drug use by the end of 2020. And if there is an infection, that it elevates it to a status of a sentinel event, which really means we make a big deal about it and figure out why someone got infected with HIV through injection drug use. So there's 2 aspects to it. One is figuring out how to do the sentinel event, and then the other other piece of it is trying to figure out how we eliminate the possibilities of HIV transmission between two people who inject drugs. So that it's greater access to sterile syringes. It's making it easier for different healthcare providers to supply syringes. Its connection to care, like through the hubs. Its connection to buprenorphine or other drug treatment, or methadone or other drug treatment. All those kind of things are ways and strategies in which we're trying to eliminate HIV amongst drug injectors. I think that's it. Yeah. I was going to talk a little bit about crystal meth, but I knew that was like an addendum, and that would be a icing on the cake at the end. So I'll end there because it's 1:45.
Thank you, Alan, for that wonderful presentation. We're going to take any questions. Let's start with 275. You guys have any questions there?
Alan, so hi, this is Tony Urbina. Great talk. Thank you so much. Do you want to talk about maybe some of the ideas that they have for methamphetamine IDUs and kind of the programs that the city has in mind for that?
Yeah, I'll talk a little bit about that, but and if I'd known it was you, I would have zipped on to the crystal meth piece. So there's been a lot of conversation. There was a lot of conversation about 15, 16 years ago about crystal meth amongst men who have sex with men and the way that it fueled HIV. And over the last couple of years or so, everyone has begun to look much more closely at what's happening around crystal meth in New York City, but also upstate New York, in terms of who's using, what ways are they using. And I think what we generally see is probably the rate of crystal methamphetamine use is at the same rate as it has been for a long time, but it's been much more covert. That the demographics have shifted slightly. That it's many more younger Black and Latino men, not necessarily in Manhattan, but also out in Queens and Brooklyn. It's still primarily older, middle-aged, gay white men using crystal meth. But that also people transition to injection drug use a lot quicker than they ever used to. So whereas it would take a little while for someone to start injecting, now it's much earlier in the career of someone who uses crystal meth. And the city was looking at this information, and we sort of paralleled this upstate and began looking. We did surveys upstate with providers to see if we were seeing exactly the same thing. And apart from the shift in racial dynamics, it's pretty much seeing exactly the same thing, that people are using crystal meth at the same levels as they've always used, that you're more likely to be an HIV positive man using crystal meth. And when I say at the same level, what I mean is we sort of felt that it had been dealt with and had gone away, and actually it had not. It had just gone below the surface, and the crystal meth is very prevalent in the community. So, and you might want to add more too, based upon what you're doing and what you know. But there's the city is concerned about it and has put some support into working with Housing Works, a harm reduction crystal meth program, working with Housing Works and GMHC, and basically taking a lot of leads from the community in terms of what is it that would really help people around that crystal meth use, and been developing their program sort of as they've gone along. Because I think there was a sort of nervousness about what they were proposing as to whether there was much structure to it, but I think that they probably did do the right thing by creating a structure, some work, put it in place, and then figure out the details afterwards based upon the input from the folks that use the programs. So that's a relatively new program. Do you want to add anything, Tony?
No, I think that's it. So yeah, we also have the Addiction Institute here in the Crystal Clear program. That's been a great kind of referral source. Anyway, thank you very much.
And we should, I mean, if you're a crystal using gay man, there's basically no specialized drug treatment for you in New York State. And we've got the outpatient programs in the city, but if you're using crystal in Buffalo, you're not going to be using those programs in New York City. So the treatment system really does not address particular populations, and it certainly doesn't address LGBT people with LGBT community and their drug and alcohol problems.
Jack Martin, I see you guys waving something. Have questions? That's not too clear. Can you guys bring up Jack Martin?
I think it said we won the lottery. Fifths. So supervised injection facilities in terms of preventing drug overdose. There's been a lot of talk around. So the supervised injection facilities are places you can go to inject drugs under the supervision of either, you could do it medically, they can be low threshold. I've seen it done with fellow peers and other drug users. You're doing it you're injecting drugs in a safe environment with the notion that if you overdose or something goes wrong in that process, you can be revived by oxygen or naloxone. They have supervised injection facilities in about 15 different countries. There's a few hundred of them, mostly in Europe. There's 2 in Vancouver, 1 in Australia, and they're about to open up a couple more in Montreal and I think Toronto. They work in the same way that a syringe exchange program does, in that they connect people to further services. So, for example, the one in Vancouver also has treatment on site, and if you go away to drug treatment, you can come back and use the beds at the on-site program. In the USA, there aren't any legal supervised injection facilities, but we've always had injection facilities in anywhere where anyone injects drugs, and people have been consciously changing the way that these unsupervised or the unauthorized supervised injection facilities have been running. There has been a lot of dialogue around this in the last few years. So Seattle, King County has moved to the place where they're going to open a supervised injection facility sometime this year, probably. And the main legal impediment, as opposed to any moral or any other impediment to a supervised injection facility, is the fact that it violates federal law, because there's a crack house statute which says you cannot distribute, you cannot manufacture, and you cannot use drugs. You can't have a space deliberately set up to use drugs. So the supervised injection facilities fall under that crack house statute. The argument could be made that if we opened up a SIF to address reduce death from opioid overdose, you are not actually setting up for people to use drugs. You're setting up as a public health intervention to prevent someone from dying. And that will probably be an argument that Seattle will use if the federal government goes after them for doing it. In New York State, Ithaca is probably the city that people most think about in terms of supervised injection facility, because they did a drug policy review of the city of Ithaca and came up with they developed a 4 pillars model, which includes drug treatment, law enforcement, drug prevention, and harm reduction. And within the harm reduction piece, there's a very little piece about supervised injection facilities, but that got all the headlines. So the city of Ithaca is one of the few places that actually could move ahead with it in New York State if they were authorized to do so, or if they went outside of government authority to do so. New York City has a $100,000 grant from City Council to study as to whether a supervised injection facility would actually be a worthwhile endeavor in New York City, and their report will be out at the end of summer, in the fall. And the data is pretty pretty persuasive from all the places that have opened one of these facilities that it does reduce overdose, it does connect people to care, it does reduce, the impact of public drug injection outside of the facility, does reduce HIV and Hep C transmissions. Mostly we're seeing the same opposition to it as we saw to syringe exchange. If you give someone a syringe, they will go out and they will go and inject drugs, and we know that's not true. But you see the same kind of knee-jerk reactions to supervised injection facilities.
Any questions from St. Luke's?
Not that the state holds any position on SIFs.
Go ahead.
Can you hear me?
Yes.
You guys can.
I can hear you. We can hear you.
Oh, okay. Sorry. I just had a follow-up to Dr. Urbina's question, which was that I found the slide about the new, younger portion of the bell curve. That was really interesting and really well summarized. I was just curious if we know what proportion of that is injection methamphetamine use versus injection opioid use.
I don't know that we know categorically, but it's pretty. I would, if sort of what you're getting at is how many of those are young MSM or young gay men, I would think it's pretty low actually. I think this is mostly related to opioids and other drugs.
Okay, thank you.
Was that all from St. Luke's? Okay. And then lastly, West, any questions here? Thank you, Alan, for your great presentation. Thank you. Thank you, everyone.
Thank you.